All right. Good afternoon, everyone. Welcome to December's 2022 Research Brown Bag here at LCU. I want to welcome everybody here in person, and then to those who are online on Teams. We appreciate you being here with us, and hope you have a good experience via Teams. It's still kind of new for us, so let us know how it is, and we appreciate your feedback, and we're glad you're here. My name is Vern Farr. I'm the immediate past president for the Nursing Alumni Association and current vice president. So I'm here to welcome you this afternoon. I would like to start us off with a prayer, and then we'll get introductions for the presentations, and we'll go on from there. So let us pray. Father God, we thank you for this day. We thank you for the many blessings that you have given us. We thank you for this university and this School of Nursing, for all the many things it has given us, not just education and knowledge, but the love this department has given to all the nursing students here. We thank you for being with us and these presenters today. They have worked very hard, and without your help, it would not have been that easy, or may not have happened at all, but we appreciate all that you do for us. We thank you, and in your son's name we pray. Amen. So I'm going to go ahead and introduce our presenters tonight. There's four of them, so I'll introduce all four, and then we'll get started with the presentations. First of all, we have Angela Allen. Angela has been a nurse for 15 years and has experience in ICU, orthopedics, and ambulatory care. She has worked at the Lubbock outpatient VA clinic for 8 years in various roles. She's very passionate in her veterans health care. She's currently Resuscitation Education Program Director with the Amarillo VA Healthcare System. Angela graduated from Covenant School of Nursing and Lubbock Christian University, and she got her MSN this time last year. So Angela is also a board member and past president of the Texas South Plains Honor Flight, and she currently serves on our Nursing Alumni board as our membership chair. So she will start our presentations, but I'm going to continue with the others real quick. The next one I want to introduce is Gisele Bazan. Did I get that right? Yay, good. Gisele graduated from South Plains College with a associate's degree in nursing. During this time, she attended Lubbock Christian University, obtained her bachelor's in 2008. In 2014, she accepted a position as critical care educator and manages the educational needs of the cardiac ICU and nephrology departments. As a nurse educator, she assists with the onboarding and training of new nurses throughout their orientation process and during their ANCC PTAP accreditation for critical care residency. Our other presenter is Kelsey Sawyer. Kelsey is also a Covenant School of Nursing graduate and quickly transitioned from her nurse tech role to bedside care in critical care. During this time, she attended Texas Tech University Health Science Center of Nursing and obtained her bachelor's in 2015. 2016, she accepted a position as critical care nurse educator. She manages the educational needs of the MICU currently, and as a nurse educator, she assists with the onboarding and training of new nurses throughout their orientation process and during their ANCC PTAP accredited critical care residency. I think I got all that right. And Tiffany Patterson. Tiffany graduated from Texas Tech University with a degree in chemistry, and while working as a unit secretary in the NICU, she decided that nursing was more of her passion. So she completed the needed pre-nursing courses and went to South Plains, and also did a CNA course through Covenant Health. She began the second degree nursing program in 2008 and completed it, and while still working as a nurse tech in NICU. After graduating from Texas Tech in 2009 with her BSN, she's been a bedside nurse in the NICU. She's also a nurse educator in the NICU, and then added to the title to include all neonates in 2020. As a nurse educator, she assists with the onboarding of new nurses through their orientation process and works with many quality improvement projects in the NICU at Covenant Children's. to find other areas of need to educate caregivers. In her first time as a nursing educator, she's worked with leadership to implement the use of milk technicians in the NICU's milk room to safely intake, prepare, and store milk for our very vulnerable population, and the installation of the NIC View, okay, cameras. Oh, I know what those are now. Okay, sorry. To help families stay connected and can log in at any time to check their little ones. I was wondering what that was earlier when I read it. Never mind, I'm a little slow some days. But again, welcome you guys online, and thank you for you guys, and we'll go ahead with your presentations. Angela?
Awesome.
Thank you.
Thank you, sir. Oh, that's fancy. Where do I need to put this? Okay. How is that? Is that okay? Perfect. Thank you for your introduction and your welcoming prayer, Vern. My name is Angela Allen, and this is the integrative research project that I put together during my master's program at LCU. And I was encouraged by my instructors, both Dr. Long and Dr. Ford, to submit to Sigma. I never thought that that would be accepted for a poster, for an oral presentation, really anything. But I got the email invitation late last year saying that my project had been accepted, and they were asking me to do an oral presentation. So it was truly an honor, and I so both want to talk about my project and my experience at Sigma, Sigma Theta Tau International, the research conference that we went to this summer in Scotland. So my project is entitled Caring for Healthcare Professionals Who Have Borne the COVID-19 Battle, an Integrated Research Review. So this topic was selected. In my class, I knew that I wanted to do something about the stress and mental health struggles that nurses and other healthcare professionals were going through related to COVID-19 and being at the bedside, caring for these really sick patients. But I wasn't sure exactly which direction I wanted to go. And I was encouraged to pursue something along these lines because I do care for veterans at the VA, and that is something I'm incredibly passionate about. And many of our veterans experience mental health diagnoses and crisis similar to how the PTSD that nurses were experiencing. And so I decided to marry the two and see what treatment modalities that we already use in our veteran population could be turned around to use for our healthcare professionals. Again, we had the opportunity to go to Edinburgh, Scotland, and present our projects at Sigma Theta Tau, and it was an incredible experience, both to present in front of scholars from around the world, people who took interest in my project. It was incredible. It was just amazing that people took the time to ask me questions and valued the work that I had done at LCU. But also to learn from them. I was able to attend many sessions about veteran healthcare, which is very near and dear to me, and lots of things that people are doing to promote veteran healthcare, as well as resuscitation education, which is my specialty now. And so it was truly amazing to make those connections and to have the opportunity to learn from individuals from around the world. Of note, I do need to say a disclosure that the VA was not a part of funding or endorsement for this project. So VA was not associated with this project at all. I did receive their approval to present it, however. Again, this was made as a part of my master's degree here at LCU. I'm employed by the Department of Veterans Affairs, specifically the Veterans Healthcare Administration for the Amarillo VA healthcare system. No conflicts of interest and no sponsorships for this project. So the questions I posed: what treatment options are available to healthcare professionals who are suffering from symptoms of depression, insomnia, anxiety, and PTSD that they during the COVID-19 pandemic? And can treatments that we already use for our military veterans who suffer from PTSD be used for healthcare professionals? So my integrated research review started the method I used, we went through sources in the Cochrane Library, CINAHL. I also used the Psychology and Behavioral Health Collection, as well as some bibliographic mining. I believe 2 of my sources were found in that fashion. The search terms I used were PTSD, COVID-19, and treatment or intervention or therapy. I included items that were full text, that included my population, which was specifically healthcare providers. And that was kind of the catch. There's so much done for patients who had experienced PTSD related to COVID, but not so much about the healthcare professionals that were caring for them. So my population, healthcare professionals as well as veterans, and those specific mental health symptoms that kind of culminate with PTSD. I excluded items that were not in a language that I could read, so anything not English, that did not include the populations I've specified, and anything that was periodical. My Prisma flow diagram. So my initial search captured 52 articles, and then I identified 2 through bibliographic mining. The duplicates were removed. I ultimately screened 51 articles and was able to get that down to 12, including 7 that were qualitative as well as 5 that were quantitative. So background information. Healthcare professionals experience mental health issues similar to those of military war veterans because of COVID-19. These issues are related to the trauma that they experience on their battlefield, which is at the bedside, caring for those truly critically ill patients. So the battlefield may be different, but the results and the, what can come of that are no different. The enemy for the last almost 3 years now has been COVID-19, and that's an enemy that we didn't know about in the beginning. It was something we were learning on the fly, and so can you imagine fighting a fight against this enemy that we don't have a lot of information on, we don't know a lot about, but we are still there day in and day out caring for these patients because that's what we've been put on this earth to do. Not only did we provide care for our patients, we sometimes had to step in and act as family members to be there and hold their hand in their dying moments, to provide comfort and support through all of the PPE, through a diagnosis that they may be unfamiliar with. And we also had to adjust to daily changes that we were experiencing with updated policy and procedure, updated methods of how we're caring. It was truly science in real time. And so we made those adjustments. My research shows that limited research has been done on this topic, specifically looking at healthcare professionals during COVID-19 and their mental health struggles. In my research, there was a study done of healthcare professionals in China about a year into COVID-19 pandemic. And you can see these numbers. I won't necessarily read them to you, but you can see the high rates of stress, depression, anxiety, and insomnia, all of which kind of lead into a diagnosis for PTSD. When those start to affect your daily life, that's how we reach a PTSD diagnosis. A similar study done in Iran showed very similar high numbers in their healthcare professionals, reported symptoms of stress, depression, and anxiety. So the sources of stress for these healthcare professionals are the high acuity patients. Again, these, especially in the beginning, now we know more, so I think maybe it doesn't feel as high acuity, but these were the sickest of the sick. During some clinical rotations in my master's program, I was in the medical ICU at UMC, and even with an ICU background, I saw peeps on a ventilator higher than I could have ever imagined possible. Patients with oxygen saturations in the 50s, yet their FiO2, their oxygen support was at 100%. It didn't make sense. These were the sickest of the sick patients. Also increased admissions. Many hospitals were at capacity. Something I've heard on the news even lately, we're in this respiratory trifecta with RSV, COVID, and the flu. My healthcare system this morning was announcing, what all we are on diversion for because we are at capacity and many of our supporting facilities are at capacity. We as nurses and healthcare professionals dealt with ethical issues. though we may not have had to make care rationing decisions, we knew that at times we were moments away from having to do that, and how would we choose to ration care if it came to that. Inadequate personal protective equipment. We all remember the beginning of the pandemic when we were making homemade masks and getting donations from our community. Poor communication from leadership, and I think that so many are quick to throw our leaders under the bus, if you will, about their communication techniques. But I feel like a lot of it, and through my research, found that it was changing just as quickly for them as it was for us at the bedside. And so I don't feel like there's a way to place blame, though, again, science in real time, we were learning as we went. Feelings of isolation, both while caring for patients, because we're in PPE, we had to be very mindful about how we went into a patient's room and dealing with our patients feeling isolated, but many had to distance themselves from their family members because of their career. As a nurse, you're caring for very sick patients, and so we had to distance ourselves from elderly family members with comorbidities, young children, to prevent them from getting sick. And so that can be very isolating. Moral injury, as defined by O'Connor, is a state of profound emotional and psychological stress resulting from a violation of a person's core moral values. And while this usually, PTSD and moral injury can go hand in hand, it often precedes PTSD. And so this is when we're having to make decisions, again, when we talk about care rationing and doing the best we can, but not being able to provide the care we want to provide. And so that can result in moral injury, which can then lead to, which is often a precursor for PTSD. Most of the literature describes prevention as the best method of treatment and being the key. So that that calls heavily on early detection and monitoring for symptoms of depression, anxiety, and PTSD. Healthcare professionals, we are often we put things down, we take care of others first, but really we have to be monitoring our brothers and sisters to say, hey, this is okay, we can talk about these things so that we can take the necessary steps to prevent mental health crisis and key into treatment for our healthcare family. Providing resources for coping techniques, and I think I've seen some of this in healthcare facilities as we've gone forward. We have learned, we are developing ways to support our staff and giving them resources. I can tell you at the VA, we have a whole health program specifically for our staff. We do yoga classes, we do Tai Chi. There's lots of services that are available to our team because of this. It was a direct result of COVID. Resilience training, again, kind of goes along with that, making sure that we equip our staff with the tools that they need. Further treatment, and these are all things that, there are not many treatment options for nurses and healthcare professionals. However, these are treatments that are used in the veteran population and can also be used with healthcare professionals. So cognitive behavior therapy, which is where you evaluate, you take that event and it really analyzes how you look at that event and helps you to kind of change the story on it. Telehealth services, which I think we can all agree is the one rainbow at the end of the COVID storm. We have increased access to telehealth. So if someone needed mental health care, they might be able to reach it on their phone. If they live in a remote community, if they don't have a lot of time to leave work to go to a provider, they can utilize telehealth services and access providers from all over the country. Mental health crisis hotlines. So many hospitals in these studies set up crisis lines for their nursing staff, and that proved to be beneficial. And we all know the update in the suicide call number, and that's something we utilize in our veteran population, making sure that we're aware of that and putting out those resources. VA also has some really great smartphone apps that are not, you obviously do not have to be a veteran to utilize. You can download them on your iPhone. It's provided by the government, so it's free of charge, but CBT Coach, Mindfulness Coach, Insomnia Coach, mindfulness and relaxation. It's amazing what you can find on your phone to help you with mental health. Psychological first aid was something I learned about during my research. Has 7 hallmarks: engagement, safety, stabilization, information gathering, connection, coping info, and collaborative services. And so this is something that a healthcare system could train a few people in that could then, be deployed to help throughout their healthcare system and really make an impact on their staff. So clinical implications: healthcare providers can benefit from many of the same treatments that we use in our veterans. VA is often at the forefront of research for PTSD treatment, and so a lot of the treatment modalities that we use in the VA with our veteran population can be used for nurses as well. But ultimately, support and empathy from the community, it's imperative. We have to have support from our families, from our communities, in order to keep our populations, keep them safe, but to also really love our nurses. And I think that Lubbock was really great at that, especially in the beginning. There was so much food all around, food and love and support. But we've got to continue that because we are still in this battle. Ultimately, more research needs to be done on the impact, and I think that we will see that done over the next few years. My references are available upon request. I would like to say I appreciate the LCU Alumni Board for the scholarship support that I was provided that enabled me to go to Scotland to present this on the international level, as well as support from LCU and my instructors, my friends, and my family. It was really an amazing experience to put this project together and then be able to share it. So thank you. Does anybody have any questions? Yes, sir.
You spoke a lot to, most of your was like the bedside nurse with PTSD. Was there anything that you found that was mentioning the leadership? Because you mentioned the leadership, we got a lot of the blame because we couldn't pass on information quick enough. Well, we were making decisions on the fly, or we didn't have the information and doing all that kind of stuff. Was there anything that worked from from that level instead of the bedside nurse?
No, most of it was the bedside nurse, and I will admit, this was done, it's been over a year now since I have, been able to go through since I found these articles, and so I'm sure that more has been done now, but this is definitely something I want to continue to monitor and maybe develop and go further with. But I agree, I think that the leadership would experience something completely different because you're feeling it from both sides. You've got your staff nurses who are stressed, and you are truly just trying to do the best that you can for them. And so that's why I'm kind of empathetic to the leader, because we were all just doing the best we could, and we continue to just do the best we can. But things were updating daily.
Because I felt I had a different level of PTSD from my standpoint. From my nursing staff being non-traditional, we're providing outpatient services. Now I'm sending these outpatient nurses and these PACU nurses who may have more experience than the outpatient, but I'm sending them to the floor to do med-surg nursing on these very sick patients. When I first had to do that, I felt like I was sending my friends to a war zone and I was never going to get them back. I was sending them out there not knowing who might get sick and die from this, and I'm not getting them back. And I know that had a profound effect on me at that point. So I know I didn't have the bedside, but everything else was on my shoulders, and for them to get what they needed and stuff like that, while we still provided some surgical care.
Yeah, and the roles are definitely, they're different, but I'm a big believer in that we are a team.
Yep.
And so yes, it affects your bedside nurses differently than it would leadership, or even myself in education. Wasn't on the front lines, but my friends were. Yeah. I have friends who work in the ICU, I have friends who work in the operating room, I have friends who are doing this, so it affects me. It affects us all, and so I think we need to be graceful with each other, and not one person's battle is not bigger than another's. But I definitely think that's really interesting, and I'd love to look into that to see what effect it had on leadership in healthcare.
Thank you.
Yeah, thank you. Yes, ma'am.
I just want to commend you for such outstanding work.
Thank you.
Really professional way in which you presented it, but I'm really deeply touched by the lens that you have chosen to recognize the reality of how stress, anxiety, and depression, of course, in its more severe form of PTSD, impacts us, but, that's a continuum. And I think what you've expressed is just the epitome of our ethical code of conduct of nursing. And that is that we're to have that for ourselves and we're to have that for others. And it just seems like in this world we hear so little of that truly. And I'm wondering even about if we couldn't lead, as you think about the divide in our nation, how we blame our leaders, we blame Fauci, we blame everybody. Those discussions and blogs still go on, and they're full of vitriol. They're full of hatred. Have you noticed this? It's just terrible. And I wonder if there isn't a voice like yours in nursing where we can say, the evidence is evolving. This is what we know, and the right choice is to be compassionate. So I just want to thank you for that. I think it's really powerful what you've done, and it's missing. It's missing in our world. So I think as a nurse scientist, a growing nurse scientist, that lens is a really powerful lens. You did a beautiful job of putting this together, and I'm so glad you were able to present it in Scotland.
Thank you very much.
Comments or questions from anybody else? Let's give it. Oh, yeah.
No, I was just cheering her on.
Let's make it up for Angela. Let's make it so it fits the whole screen.
Oh, gotcha.
Can you do
That's a
that?
tough follow-up.
But it fits beautifully.
It does fit, but we should have gone first.
No, it's perfect. What you all are doing is
Show us up.
perfect.
We're just going to hold it. Okay. Hello.
Hello.
Hi. Phil, how are you? Again, thank you guys for having us come and present. Again, my name is Gisele Bazan. I have Kelsey Sawyer and Tiffany Patterson with me. We also presented in Scotland at STTI. Thank you to LCU for giving us the opportunity and the coaching guidance we had as well. So we had a very, very fun time presenting on an international level. What our study was over was mindfulness bundle impact on nurse burnout. At the top, you see our team members. 3 of them are here present with me. And you see Jamie Rooney, which was part of our, if you guys know her, most of us do. She was part of our research study and was very instrumental in giving us lots of guidance and coaching throughout this process. We did have 2 bedside nurses who were very passionate about burnout and the effect it was having during COVID. That was Michelle Bradbury, which is a medical ICU charge nurse, and Wambui Kamau, who is actually a LCU alumni, who is now an FMP at UMC. And then Cindy Grissman, which is also an LCU alumni, see a trend here. And she was a nurse manager on CICU, and then Sinhar Mihindaus, who was very instrumental in helping us and giving us some coaching guidance on some previous studies she had performed, as well as Randall Stinnett and, of course, our lovely Dr. Long. So I'm just going to go over this. This study started kind of along the lines of what Angela did as well. It was during the height of COVID, the pandemic in 2020. What we saw at Covenant was 2 units that were designated to be the first COVID ICU floors, seeing the first COVID patients that we were having in this area and region. And then I'm going to let Kelsey go over the background because that was her part that I took over last time. So
Thanks. Okay, so our background is nurses caring for COVID-infected patients during the height of the 2020 pandemic experience higher levels of burnout. This is particularly important for the ICU and ED nurses that are seeing more critical patients. They're seeing the fetal care patients. Prevalence of nurse burnout can be as high as 40%. That's a really high number for nurses, especially during something as stressful as a pandemic like COVID. And when this was taking place. It was the height of our big wave in Lubbock. It was October of 2020. So that's our big wave. Higher levels of burnout can have a negative impact on job satisfaction, patient outcomes, and increase nurse absenteeism and turnover. So basically, how much you love your job, how long you want to stay in your job, and whether or not you come to work every day. So they're experiencing burnout at 40%, and they don't want to be there. They hate coming to work every day, and they're probably going to leave. We saw that all over the media, right? All over social media, all over the news, nurses reporting that everywhere. Mindfulness-based stress reduction programs have been utilized to help decrease that burnout, is what we saw throughout the evidence. But there's no gold standard for any sort of outcomes for nursing mental health, as Angela pointed out. Intensive care nurses have reported the highest rates of burnout, again, because of the fetal care that we were seeing, and families weren't able to be at bedside. We were that primary person to help the patients onto their next journey, and that's a lot to process as a nurse. And then studies have demonstrated strong relationships between nurse work environments and job satisfaction, work-related burnout, and intent to leave. So the environment that you're in lets you, relates to your burnout and whether or not you want to stay in your job. Which leads into our research question. What effects does a mindfulness burnout toolkit have on Maslow Burnout Inventory, MBI, Nurse Work Index, NWI, and Stress Arousal Checklist, SACL, scores in nurses working in critical care units designated for care of SARS-CoV-2 patients? I'm going to hand it over to Tiffany to talk about our methodology.
Hello. So because there's not a gold standard, where do we go from here? How do we make this work for our nursing staff that are going to leave, or they're just not going to show up to take care of these patients? So we did a quantitative quasi-experimental repeated measures design, and we utilized our IRB's approved study. Intervention group consisted of these 2 ICUs that they spoke of that were the first designated at our facility in our ministry, caring for the sickest of the sickest patients. The study participants consisted of 52, which is really convenient sample, but if you look at it, we had narrowed it down to full-time registered nurses in the ICU. So that's a huge sample across just 2 units. We provided a 12-week bundle toolkit. So we couldn't decide on just like 1 or 2 things because there wasn't a gold standard. And so looking at all of the research and going through it, we found that there were, across most of them, several things that they said that worked well for mindfulness and just self-care in general. So the interventions included approximately 1 to 1.5 hours per week for actually 12 weeks, right, of intervention, including we had this fantastic room that administration helps with providing that had a yoga mat. It had a massage chair that I think they've worn out now. They're getting a replacement. We got some at our hospital too. Blue lights, greenery, they had music. What else am I missing in that room? I think that was the major things in the room. Oh, snacks, nourishment, people like food. Just a place to get away. So it was a nice place that they could take 5 minutes and get away. So at first we thought this would be more taboo because people didn't want to say that they were having trouble or they were struggling. But then it became the most popular room in the hospital because they want to get away. And then you had people coming from other units, from the pharmacy, that wanted to come into this room to take time to relax and de-stress. We did a resilience or a yoga class that they attended. Again, didn't think people would show up to this because who's going to go to a resilience or mindfulness class? But they did, and it was amazing. And then off the record, they saw nurses at the bedsides, the desks in the units, doing these stretches and things to help rejuvenate themselves. They worked. So it was really cool to see. I'm hoping we can do those for everybody. What else did we have? We had a cool little reflection book, and I didn't bring it with me today, but it had the whole time that we did the interventions, it had a reflection for each day. They could be little things, scripture that were biblically based and all had meaning to what nurses do. They could be simple action items like, hey, go tell someone they did a great job today. Like call someone out, let them know that they're doing a great job. Or reach out to someone that you haven't seen in a while. They were simple tasks that took less than 5 minutes that they did at the start of every shift. And then each nurse had one to take home. And they were pretty. I tried to make them pretty. We did collect data at 3 time periods for these nurses that were in the intervention group. The descriptive analysis was conducted on all the study variables, so we looked at everything. And then normality was examined for intra-level dependent variables. Let's pass it on to Gisele.
Maybe. Sorry, they're going to hear a lot of background noise. I need help with everything in my life.
Okay, we got her.
I hope that's not on camera. Okay, a little codependent here, sorry. Okay, apologize for that. So our analysis and results. So we collected our data 3 time periods, and what was performed by our lovely Dr. Long, our statistician, was a one-way repeated measure analysis of variance, an ANOVA. This was conducted to determine the effect size of the mindfulness bundle of emotional exhaustion, personal accomplishments, or PA, and depersonalization, DP. Those 3 are subscales of the Maslow Burnout Inventory, the MBI. And we also looked at the nurse work index, which Kelsey mentioned, and the stress arousal scores. So what the results and analysis indicated was statistical significant effect size of the mindfulness bundle on frontline nurses on these 2 COVID floors. So what we had for emotional exhaustion was we had a statistical significance of 0.005, and with a large effect size of 0.31. For depersonalization, we had a statistical significance of 0.007 with a small to moderate effect size of 0.16. And then on the stress scores, we had a significance of 0.005 with a small effect size of 0.17. So those are amazing results that we came up with once we collected our data and had it analyzed. And that was a lot of data entry. If you guys have ever, and we did it on paper. We did not mention that. I want to say we did it on paper. I would not do it on paper ever again, by the way. But that was a lot of fun. So discussion and clinical implications. So as Kelsey mentioned, there's no standard practice or guidelines to measure or help mitigate with burnout. I think also Angela had mentioned that too. Like there's just all these ideas and buckets out there, but it's not one size fits all. That's what we know. It's not one size fits all. Everybody approaches everything differently, and there's inconsistencies found among the mindfulness-based programs and interventions. So that's why we kind of selected once we looked at the literature, what was effective, what did work. And the interventions were easy to implement. These weren't high costs, they weren't high time. It wasn't taking a lot of the nurses' time to complete these tasks. And so it's a low-cost program. We do have a new chair coming, so we're excited. So they were utilized a lot. And it's not limited to just nurses. So as mentioned, we had other departments coming to use our mindfulness room. They didn't get all the interventions, but they were still enjoying the mindfulness room, such as our respiratory therapists, our pharmacy, our physicians were utilizing that were designated to those COVID floors. Oh, gosh. Okay, so I get to close it out. So our study findings suggest that the use of a 12-week mindfulness bundle toolkit is effective to mitigate the Maslow burnout inventory. So that is going to consist of your emotional exhaustion, your depersonalization, and stress linked with burnout in critical care nurses. Okay. Significant effects were not found from the mindfulness bundle toolkit on personal accomplishment and the arousal scores.
We did see some changes. They just didn't quite meet that level of change that we were really looking for. And then replication of the intervention with a larger randomized sample would be recommended. We'd really like to see it in much bigger numbers to see how the statistics improve. And although not reported, nurses expressed appreciation for the interventions. Like Tiffany was saying, Gisele and I both saw our nurses on the units practicing the stretches and doing the different techniques throughout the unit after their classes, and using these rooms and telling each other to go and take a break, and really putting these mindfulness techniques to use and looking after each other after we put this toolkit out for them. SARS-CoV-2 highlighted the burnout nurses globally had been experiencing, and this may have contributed to the mindfulness bundle toolkit being embraced so wholeheartedly by them. I think we've all, as a profession, been looking for something to help with our burnout, and I really think that's kind of why they grabbed onto it so well. So they've really enjoyed it. As we've all reiterated, the massage chairs have done really well. They enjoy it so much. And the books were great during huddle. They would go through and read the reflections and just start their day off on a really good note, especially during the height of that pandemic, to start off on a good note and continue the day that way and know that they had a place to go and just take a couple of minutes to get away from it was really great for them. Any questions?
I was just going to add, so as a follow-up, I mentioned that our little house, the children's hospital, we call ourselves the little house because they're the big house. We now have 3 massage chairs that are now rotating, and we just got them last month. So we've been rotating them at the hospital, because when I went to the pathway meeting that we had, I was like, our nurses in the PICU and the NICU were our control groups, because we didn't have another group that hadn't been affected. So they were the best as far as ICU nurses that didn't see this huge wave of COVID at first, and then we got our fair share. But I was like, this room, guys, has huge impact. And we showed them, we talked about the evidence from the study. And so they got permission and got funds from our foundation, and were able to purchase 3 chairs. They're now rotating out throughout the children's hospital. And one of the units actually just bought one for their staff for Christmas and are creating a room. So it's really awesome that they've seen the value in what has been done and what has worked, and they're excited to be able to utilize it themselves. So it was impactful for sure. Questions, you guys have? It's really awesome.
It's awesome. I want to know what advice you would have for frontline nurses, because you all were some of the first frontline nurses to actually lead a study. And that's part of Magnet. But what are your takeaways as clinicians who got out there and led a study? What would you tell other frontline nurses who say, I want to do this? What advice would you give them?
Don't do it on paper.
Very true. Don't do it on paper. Don't do it on paper. Find a good mentor, a trusting mentor. Find a good mentor. I would say don't be scared, and don't be worried about the results. Like I think we want to drive our results and push them one way or the other, and whether or not, if you implement a study and it works or doesn't work, your results are favorable or not, it doesn't matter. It can still impact something. It can lead future research to know, what, this didn't work well, so let's not do that. So either way, it's still good information, even if it's not the results you want in the end. And don't let that discourage you.
I'd say pick something that you're passionate about. I think that's why this went over so well for us, is because it was our units, and we were very concerned about our nurses and what they were going through. And because we're passionate about our nurses, we put a lot of effort into it.
Bring a friend. That's what I was going to say. Bring a friend. Find someone who maybe has a different lens, like we've talked about before, sees it a different perspective, because I don't work in these units. I've worked in SI before, but I've never worked in these other units as full-time nurse. I was a student. So I knew these nurses, and I was in a random meeting one day, and one of them was kind of spilling what was happening. I mean, she was in tears. She had me crying. And I was like, we've got to do something. And then they were like, hey, do you want to join this? Yes, because they need it, and you can see it across their faces. So, and then my nurses were terrified because we got a survey that asked, do you know how to prone a patient? And we were like, yeah, we've been doing it for 30 years, absolutely. And then she came back, she was like, hold on, is that for like a NICU baby? Because I can prone a NICU baby like real easily, but not an adult. We were terrified. So, yeah, bring along a friend.
I've got a follow-up. I don't mean to hog it. Do you have questions?
No.
You mentioned that this is really important. Your findings are really important, and they have had an impact. But to have a greater impact, we need it probably replicated somehow, somewhere else. Maybe with it'd be great if we could have a randomized study, and that usually happens when the study findings get placed in the literature and people actually have access to it. And you did a fantastic job with this, and I'm so proud of you. And what you did in Scotland was amazing. But for it to really have the impact it needs, it's got to get published, because that's when it's accessible around the world. So what is your strategy and your plan, since publishing is a marathon and not a sprint? I mean, it's really, publishing is not for the weak of heart, because it takes it's a long, hard road. Where are you at in your thinking? Even just what's up here, what are your strategies for taking it forward?
You want to take that? It's all on team spots. Just kidding.
Well, yes, yes. We're looking at publishing. We are needing to get back together and recollect. We have discussed it several times, so that's kind of our goal for 2023, is start working on getting meetings together. You know, and unfortunately, it's unfortunate, but lots of changes are happening where we're at, and so it's just kind of it's just been on the back burner, but we need to bring it back forth and refocus on it. So I believe that was our goal for 2023, is to start looking at scheduling meetings, to start writing and working on different sections of the work.
So proud of you.
I have a question.
So proud.
So I would be interested to see the implementation of this in a more outpatient setting in the nursing world. So like those of us that work in small clinics, rural health, we had a very significant amount of burnout in a whole different way. So I'd kind of like to know, because we don't do some of the things that y'all talk about, how could we implement something like that in an outpatient setting for our professionals, and how we apply that?
So I think because of the interventions that we picked, because burnout is very individualized and the way you treat it is individualized, I think this can go anywhere. It's inpatient, it's outpatient, so any of these interventions can be applied anywhere. And as long as you have an hour and a half a week to do it, I think it'll work. So.
And just like Angela's study, the previous study mentioned, yoga classes, mindfulness classes, I believe was there, or mindfulness coach training, things like that. You can, that for your clinics or anything like that, you could, hire somebody to do mindfulness training and teaching classes for the staff.
It's kind of anecdotal, but did anyone say, I was going to quit, but now that I've done these interventions, I'm going to stay? Did you have anybody report that, or because we have so many people leaving the profession right now? We need to know what will keep them.
No, I wouldn't say those exact words. I feel what I heard off the record was more of they're hearing us and they're seeing us and they care, instead of we're burned out, we're working. I think they saw it as, there's no way to fix it. Like you can't just push a button, snap a finger, and it's fixed. But knowing that there's efforts being made to help that problem that they were having mentally, emotionally with the burnout and exhaustion.
I think we could pull the data and compare our 2 units to the other 2 ICUs and compare the turnover rates, because the other 2 ICUs didn't have this intervention, and see if improve that, but not anecdotally, no. I did have a lot more people on my unit that were much more open to going to therapy and started therapy that weren't open to it prior to this, so I don't know if that helped, but not anyone outright saying I was going to quit, but now I'm going to stay.
I think if nothing else with COVID, the sad thing is, unfortunately, that it brought burnout to a head where it was okay to not be okay. We've all heard that. Even now to this day, we have nurses asking for our free services that we have, counseling, things like that, knowing that there's resources available, that we have made it up, it's up there, there's no shame coming and approaching managers, educators for this information. It's sad that it took COVID for that to happen, but it's not, nobody's hiding, no one's, keeping it to themselves and holding it in. So it's a positive, I guess you could say, a silver lining, but still. Anything else?
I'm so sorry, I overlooked you. Well, I just want to say how impressed I am really with the work that you've all done. It's really remarkable, isn't it, to see nurses at the graduate level, just at a master's level, pulling projects together like this, having such a deep appreciation and respect for the scientific literature, knowing how to handle it, and doing something that mattered. And what you've done really matters. And I just want to commend you for that, and thank you for representing the profession so well. The compassion that both of your studies show is something that we still very much need for ourselves and for one another. So thank you for that. I'm really proud of all of you. Appreciate the Alumni Board supporting this as well.
Yes, very grateful.
Fantastic job today, both of you.
Thank you.